So I'm just going to start by starting off with the two esophageal cases. There's a lot of verbiage, but I'm going to go through it just briefly. And then Dr. Mulcahy will talk about esophageal cancers. So the first case is a gentleman, 67 years old, who presented with a history of dysphagia. He had an EGD that demonstrated a distal esophageal mass, 37 to 42 centimeters from the incisors, encompassing about 2/3 of the circumference of the esophagus. He had a biopsy. The biopsy did show adenocarcinoma, moderately differentiated. He also had an EUS, appropriately, which showed the distance from, again, the incisors, which was congruent, 37 to 42 centimeters from the incisors. And by endoscopic ultrasound, a UT3N0 tumor. His BMI was 22. This is his EGD, and you can see the ulcerated mass in picture 1 and 2. And this is his EUS. And you can see the invasion into the adventitia. The PET scan, the helpful red arrow, shows us where the tumor is right at the GE junction. And the patient that was discussed at tumor board and underwent neoadjuvant chemotherapy with radiation, IMRT 50.4 gray, followed by surgery, and he had a good response to therapy with a YPT1A, and again with no lymph nodes involved, margins negative. So this is our first case. I'll go on to the second case, and then both will be discussed. So the second case is a gentleman, 47 years old, who noted a significant amount of weight loss, 45 pounds, and a history of 3 months of dysphagia. He did have a history of alcohol abuse. On EGD, there was a large fungating ulcerated mass located 33 to 40 centimeters from the incisors. Again, this was a moderately differentiated, that's a mistype there. It should be squamous cell cancer, so I apologize for that. The EUS did show the tumor again from 33 to 40 centimeters. What was important was that it showed invasion through the adventitia, so a T3, but there were several lymph nodes involved, including a left lower paratracheal lymph node, measuring on its largest axis 2.4 centimeters. PET scan did corroborate this data. So this is his EGD and his EUS. And then this is his PET scan, where you can see the upper paratracheal lymph node. And these are key CT images. And he again underwent concurrent, potentially definitive carbotaxol with radiation, and this is just his radiation field. So I'm going to turn it over to Dr. Mulcahy to discuss these two cases.
All right, thank you, and thank you for having me. I'm going to discuss esophageal cancer somewhat in general, but we can come back and refer to the cases as we go. A couple things I wanted to make sure we cover is the first step we have to do is just how to evaluate this patient with esophageal cancer, any patient. And as many of you know, the AJCC has recently updated their staging, so I do want to talk a little bit about the differences between the 7th and 8th version of the AJCC staging for this. The importance of histology, we have two cases, one with adenocarcinoma and one with squamous cell cancer. And for any esophageal patient, we need to respect their medical condition. These patients can be potentially very ill, and making sure we're maximizing their overall performance status in order to tolerate whatever treatment we have to offer them. And then I want to talk about the different treatment options. There are many clinical trials have been attempted. Some have been completed. These studies are very difficult to do. It's not a common disease in this country, and trying to identify people who have a reasonable performance status to be enrolled in a clinical trial. And when we talk about clinical trials, as a medical oncologist, I can tell you it's pretty easy to offer a patient a clinical trial with drug A or drug B. It's a whole different story when you're adding radiation or no radiation, when you're doing surgery or no surgery. When you're doing these big, adding other modalities, it's much more challenging to enroll patients in these, for patients to be randomized. So we have many clinical trials that have been attempted, maybe halfway completed, and stopped due to poor accrual. But that's the data we have, and we have to take this data and make clinical judgments based on it. So we're going to go through some of those studies as to why these patients were treated the way they are. We'll look at pre-op therapy, chemotherapy, chemoradiation, and some new data that helps us understand the role of post-op therapy for these patients. So first of all, the staging. Now, when I see a new patient with esophageal cancer, they generally come to me after they've had their EGD and their biopsy. So we know if we're dealing with an adenocarcinoma or a squamous cell cancer. So the way I approach this, and when I educate our residents, it's to start big and go small. So the first thing we want to do is make sure there's no metastatic cancer, and a CT scan does that. So by obtaining a CT scan, if there's metastatic cancer, you're done. You've staged them. You've staged them as a stage 4, and there's no need to go any further. The next step would be your PET scan to identify metastatic disease, occult metastatic disease. Up to 25% of esophageal cancers are restaged based on a PET scan, either upstaged or downstaged. You can have you can have CT scan that shows some enlarged lymph nodes that do not show uptake on PET scan, or you can have some lymph nodes that you didn't detect up in the supraclav region from a GE junction adenocarcinoma. So 25% of the time your stage changes. The endoscopic ultrasound comes into play after there's no metastatic disease. And then for early stage cancers, your T1 tumors based on endoscopic ultrasound, an EMR, endoscopic mucosal resection, or an endoscopic submucosal dissection might be appropriate to stage that T1 cancer. Now, that's a conversation to have with our gastroenterologists, and I wasn't going to say anything more about that. Now, we know, and we just saw in those cases, this is usually not the order that things happen. Somebody's found to an esophageal, they undergo an EGD. We suspect an esophageal cancer, they have an EGD. Frequently, they have the EUS right then. And if there's metastatic disease, there was no need for that EUS. Instead of a patient getting a CT scan to look for metastatic disease, they get the PET CT right off the bat. And so things don't always go in this order. But to understand what we're looking for when we're staging patients, it's important to just understand the role of each study, the point of doing each study. So some of the things, as I said, for the EUS can help you distinguish a T1 or T2 tumor from a T3 or T4. It's not so good at distinguishing a T1 from a T2, but you can break up into those big groups. Your EMR or ESD can be helpful for your T1 lesions. And identifying clinical lymph nodes is probably one of the toughest parts of this. And I listed 3 studies there, the EUS, the CT, and the PET. All of those are used to identify lymph nodes. And this is clinically, not by pathology, not by biopsy. And as you can see, the accuracy of each of those are about the same. The sensitivity is about the same, and the specificity is about the same. So none of them are perfect, and we look at the combination of all this to make a clinical judgment as to what our patient's stage is. So any of these tests have something to contribute, but none of them are perfect. So in the AJCC 8th version, the group staging, there's a number of changes. Some of them are really favorable. One of them is that post-neoadjuvant pathologic staging is now included. In the past, that wasn't included. We had clinical staging, which is based on your scans and your biopsy, and you had pathologic staging based on your surgical resection. There is now a group staging for YP, post-neoadjuvant treatment, pathologic staging. And this is important because we would see these cases that had, after chemoradiation, would be T0 and 1, and it didn't fit into any of our group staging categories. So now there's the pathologic post-treatment staging. And interesting, this group staging after treatment is the same for adenocarcinoma as it is for squamous cell cancer. So in clinical staging and pathologic staging, there's a difference in the group staging for each of these histologies, but if people have had treatment, it's the same. This is a start. There's not a lot of subgroups in this YP group staging system, but it's a start. We'll start looking at these, we'll see what the outcomes are for each of these groups, and start over time, we'll be able to define this better. But for now, the start is that it exists. So there's now a group staging where these other situations will apply. The site of the disease is now measured at the epicenter of the tumor. It used to be the upper border of the tumor. It's now at the epicenter of the tumor. For esophageal cancers that go into the gastrocardia, the epicenter of the tumor must be less than 2 centimeters. So this is still not a great system. Hopefully, they've reserved for our 9th version molecular characteristics of these tumors. Right now, there isn't anything in the staging system that accounts for any of the molecular profiles of esophageal or gastric cancers. But hopefully that's on the docket for the 9th version to get a better understanding of how do we distinguish between esophageal and gastric cancers. In the prior staging system, grade, the grade of a T1 tumor was a pretty important factor in deciding what to do and how to stage it. For clinical staging, that is now eliminated because it was not a good predictor. Grade based on a fine needle aspirate or on a small biopsy was not conclusive. These tumors are heterogeneous, so to call something a grade 1 and make your treatment decisions based on it when you just have a fraction of this tumor specimen was not appropriate. So grade has been eliminated. It still does play a role for pathologic staging. If you have a pathologic specimen that's a grade 1 T1 lesion, you may not need any further therapy, whereas if it's a T1 grade 3 lesion, you may opt for more therapy. So grade from the clinical staging is eliminated. And then oftentimes after chemoradiation, we see these acellular mucin pools. And we have this discussion at our tumor board all the time. Sometimes the pathologist will report on 14 lymph nodes with acellular mucin pools, and we don't know what to do with that. So this staging system, they've looked at what's happened with these patients, and essentially they came to the conclusion, disregard it. If it's negative, it's negative. If there's no cancer cells, even though you could have 14 lymph nodes that have acellular mucin pools, if there's no cancer cells there now, it's an N0. So these are some real positive changes that have been made. And I've got the reference on there. It's a recent paper by Dr. Rice, who's worked on these staging systems for a long time. So it's worth taking a look at. So when we're talking about their medical condition, once we have them staged, then we have to assess their medical condition, and this is a wide spectrum. We can have people that are perfectly healthy who have a tumor found on a screening endoscopy to some of the sickest patients that I take care of. So it's a very wide spectrum, and the biggest issue we run into is nutrition, and this will vary from institution to institution on the best way to manage someone's nutrition. And if anybody has any data to support these, I'd be happy to look at it because it's something we struggle with all the time. Whether they can tolerate just some dietary modifications with a soft diet, having enteral supplements, do they need the G-tube or the J-tube? If you're gonna put a G-tube in, you better be talking to your surgeon about where that G-tube is going. So these things, the role of a stent. Stents are becoming more and more common. And the only clinical trials you really find in the literature about nutrition for esophageal cancer is when some new stent is coming on the market. And they'll have some new stent versus a J-tube, or some new stent versus TPN, or something, and that's really the only data you can find. So there's not a lot of data to support the proper feeding mechanism for people with esophageal cancer. It's just a struggle. And we know that these patients can become pretty malnourished pretty quickly. So then we move into our treatment options, and I'm going to go through a bunch of quick studies just to kind of lay the groundwork for why these decisions are made for esophageal cancer. Now, single modality therapy may be appropriate for very early stage, low-grade tumors, your T1 grade 1 lesion. But aside from that, multimodality therapy has been shown through multiple clinical trials to be beneficial. And as I said, many of these clinical trials have not been completed. They get stopped due to poor accrual. But we gather all that data, and we have to look at these combinations of data because that's all we've got, and we've got to make these decisions. So what we're looking at in a lot of the studies I'm gonna present have to do with what modalities and what sequence, pre-op, post-op, whatever. So I've listed some there, and we're gonna take a quick look at some of these studies, and then we'll go on to some newer stuff. So the first one that I mentioned there is this pre-op chemotherapy. Sorry, it says chemoradiotherapy, it should be chemotherapy. This is the MAGIC study, and it was 500 subjects were enrolled. Half got chemotherapy with epirubicin, cisplatin, and infusion 5-FU, and the other half just went right to surgery. And it was shown that there was a survival benefit in those that got the pre-op therapy. Now, 75% of these subjects in the study had stomach cancer, 25% had esophageal. So it's a pretty good number of esophageal, but it was predominantly a gastric cancer study. We did extrapolate to use these regimens for esophageal cancer, however. This ECF regimen has really fallen out of favor. And as Tarita said, I am on the guidelines for the esophageal panel for the NCCN guidelines, and I've been fighting for years to get this whole epirubicin regimen out of the guidelines, and we actually might have succeeded this year. So I think epirubicin, there's no role for it. It's platinum and 5-FU. It always has been, and it still is. Those are the best treatments that we have for gastric and esophageal cancer. The next study I want to talk about is the ACRO study. This is similar, perioperative chemotherapy compared to surgery. This study was predominantly an esophageal cancer study. So this one came along later. The treatment is platinum and 5-FU. And 75% of these patients had esophageal cancer, 25% with gastric cancer. And again, we see a benefit in 5-year overall survival, disease-free survival, R0 resection. There's a benefit in giving preoperative therapy. Both of these studies were designed to give pre-op and post-op therapy. Post-op therapy after an esophagectomy, after a gastrectomy is very difficult. So they actually weren't able to report on that data. The studies weren't powered enough to report on the role of the post-op therapy. So that's why it is all reporting the pre-op therapy, and there is a benefit. So moving on, this was the big one that made a big practice-changing study. It's known as the CROSS study. And this is preoperative chemotherapy and radiation for esophageal or GE junction cancer. So this is specifically an esophageal it's not just adenocarcinoma, it includes squamous cell. About 25% of cases had squamous cell and 75% were esophageal adeno. This regimen was carboplatin and paclitaxel, given once a week. So the benefits of this are that they're not carrying around a pump. They're not constantly getting infusion, which is good, lowers their infection risk. It's more convenient for the patient. The efficacy compared to platinum 5-FU, we don't know. They've never been compared. Looking at, if you compare these studies, not comparing the regimens themselves, but compare the studies, the outcomes look about the same. So carboplatin and paclitaxel given weekly with radiation is pretty much a standard of care for esophageal cancer. Platinum and 5-FU is still a standard of care, but this is better tolerated and for most patients and more convenient. The path-CR rate is what we always see when we do these. We've got about 30% path-CR rate. That's what's been reported in study after study, looking at multiple studies. So the next one is the POET study. Now this is a smaller study. This is one that was designed to look at preoperative chemotherapy compared with chemoradiation. So this is a study that we want. Are we adding something with radiation? So this study closed due to poor accrual. Because as I said, when you're randomizing people to different modalities, it's really hard. People want their doctor to tell them what to do. They don't want a computer to tell them what to do. So this was a tough one to accrue to. It was stopped early, but we still got data out of it. And it showed, as you can see here, the blue line is the chemoradiation arm. So that top graph is overall survival, and the median survival was 33 months compared to 20 months for chemoradiation compared to chemotherapy as pre-op therapy. So it's showing that there is a benefit even though it's a small study. What I really like out of this is the bottom graph. That's looking at your lymph node negative disease. So those patients that had lymph node negative disease at the time of surgery had a significantly better survival. The patients that got chemoradiation had a higher chance of having lymph node negative disease. So when you can, chemoradiation, I think we've now got enough data for esophagus and GE junction cancer that chemoradiation is preferred over chemotherapy alone. Now here's some of the newer stuff, just a couple more slides. The utility of adjuvant chemotherapy. This is a big question. So you do chemoradiation and then surgery, and now what? We're looking at these tumor specimens. If there's no response, we feel like we want to give something, but what we just gave didn't work. If there is response, do we need to give anything more? There's arguments on both sides of what to do. What is the right thing to do? What they did here was they looked retrospectively. So they looked at everybody who got adjuvant therapy. So it's not a perfect study, as I said, but I think there's still something to be learned. The top graph looks at the overall cohort. This is people with that got neoadjuvant chemoradiation. Different drugs, different regimens, but they got some chemoradiation. They then had surgery. Some of them got adjuvant therapy, some did not. It was not randomized. So the top panel, the left graph is looking at the overall cohort, and the right graph is just those with adenocarcinoma, which was most of them. So the adenocarcinoma ones kind of mirror the whole cohort. The middle graph is looking at those stratified by residual pathology. How much residual disease was there? Is there disease or not? So the top two curves there are no residual disease, and the addition of adjuvant therapy really didn't add much. That's the gray line. The bottom two curves are with residual disease. And as you can see in the bottom two curves, there's a slight difference between them, but it's not very large. The bottom one is the interesting one. This is looking at lymph node negative disease. So the top two curves are lymph node negative disease, and the bottom ones are lymph node positive. And if you look at the one on the right, your right, you can see that those curves are split. That gray line up there are your lymph node positive disease that get adjuvant therapy. So that's a difference. That's where you've impacted this disease. So based on, this is something that I really felt that I could use. Based on this, if somebody has lymph node involved disease at the after surgical resection, given more chemotherapy can be beneficial. So the last piece I want to show you is an interesting study that was just reported at the GI Symposium just a few weeks ago. And again, this is combining a number of cases. This is something that can apply to many disease sites in the GI tract. We often give chemotherapy and radiation, and there's been a lot of debate as to when to operate, and I'll be interested to hear your take on this. So this study looked at, they had 1,000 patients in each cohort, and they looked at the time to operation. And they found that there's a sweet spot in here. There it is. So after about 60 days, you have the highest response rate with the lowest mortality. If you start going beyond that, you get into that last cohort, the mortality goes up significantly. So there is a sweet spot of about 60 days is the time to operate after chemoradiation. And this is an esophageal cancer. And I know there's some data in rectal cancer, and I'm not sure if there is in pancreas cancer as far as the timing from completion of chemoradiation to surgery. But I thought this was something new that, again, is helping us deliver better care for these patients. So here's the actual numbers, the quartiles. The median overall survival in that 54 to 64 range is 33, with a 5-year survival of 36%. You start going beyond that, and the mortality increased. So based on all of this, I feel that we are making some progress in esophageal cancer slowly. Unfortunately, a lot of times we are stuck with data that is not perfect. The studies aren't powered perfectly, and that's what we've got, and we have to make decisions based on it. And I think there's enough studies and there's enough cumulative data that we don't have to keep redoing these studies. We don't have to keep looking at multimodality therapy versus single modality therapy. We know it's better. Now it's a matter of trying to understand the molecular biology of it, trying to find better agents, looking at the checkpoint inhibitors, and trying to really understand how we could make those big impacts. But for right now, and for these cases that you saw, I don't know if we want to go back and look at them. Do we have time? Okay, we can go back to that. But in the cases that you saw, they reflect this data that I just presented. It used the carboplatin, Taxol, and radiation therapy. There was a time frame until resection. So really understanding the staging, what the options are and why we choose them, and then trying to better define the right timing of all these modalities, how to use them best. Thank you.
Thank you, Mary. That was really wonderful. We're going to move on to the next cases, and these are going to be our 2 pancreas cases that we're going to discuss, and then Dr. Evans will give us his thoughts. The first case is a case of an immediate resection. This patient is 55 years old. She's a woman who declines any sort of neoadjuvant therapy. She goes to surgery, and she's found to have a pathologic T3N1 disease with 3 of 27 lymph nodes positive. The tumor is noted to extend into the ampulla, the duodenum, and the peripancreatic soft tissue. There's positive perineural invasion and lymphovascular invasion, but the margins are negative. The CA 19-9 has a good response to the surgery, going from 60 to 16. The patient is then discussed in tumor board and enrolled in clinical trial RTOG 0848, which is chemotherapy followed by randomization to chemoradiation. The patient undergoes adjuvant chemo of gem Xeloda for 6 cycles, and restaging shows no local progression of disease or distant disease. She's then offered adjuvant radiation, which she accepts as 50.4 gray with concurrent Xeloda. This is her radiation plan, and she did well through treatment. The next case is a case of a borderline resectable patient. It's a 65-year-old gentleman with new abdominal pain. He's had imaging that shows an ill-defined mass that's in the pancreatic head, measuring 2.2 centimeters. There is some ill-defined enhancement surrounding the mass. There's noted to be soft stranding within the mesentery along the medial margin of the vessels SMA and the SMV, but there's less than 180 degree of involvement of these vessels. These are some of the cuts through the axial and the coronal versions of the patient's imaging, and you can see in the lower right-hand side the vessels. The patient, again, is discussed in tumor board and is also placed on trial on the Alliance trial with neoadjuvant FOLFIRINOX and followed with SBRT, 33 grays in 5 fractions. We're going to have now Dr. Evans talk about these 2 cases.
Thanks very much, Tarita. Well, thank you all. It's great to be the token surgeon in the room. And as many of you know, my bias is strongly in favor of neoadjuvant therapy. Certainly for the first patient that was brought up, I've never had a patient, I was a chief resident actually 30 years ago, I've never had a patient refuse neoadjuvant therapy, and it's simply because I remind them that what if they succumb to the disease, it probably won't be from what they can see on the CT scan. It'll be due to the micrometastases that are present in virtually every patient at the time of diagnosis. So as you'll see, certainly in my opinion, there really is no role for surgery straight away in this disease. The problem with neoadjuvant therapy is illustrated here. It takes really a village to take care of these patients. So if you're giving a patient neoadjuvant chemoradiation, you're giving them typically weekly gem or oral capecitabine, and the medical oncologists there probably aren't any medical oncologists in the room, right? So I can, other than on the stage. With Mary here, I have to be careful what I say, but let me say this. Oftentimes, they're not as maybe engaged as would be if you were given FOLFIRINOX or gemabraxane or full-dose therapy. The surgeon may or may not operate on the patient, so oftentimes, the patient may have leprosy. I mean, who is going to take care of the patient when they're given neoadjuvant therapy? It is the major impediment to this disease. I think if I can leave you with one goal at the end of this brief talk, it's to have a clearly defined plan for every patient. You can only have a plan if they're accurately staged. And in fact, when we wrote the first trial of neoadjuvant therapy during my fellowship now a long time ago, that was the first time that we actually had to stage patients with CT imaging. And you can see here, I don't know if I don't have a mouse, so I don't have a pointer, but in general, there is rough consensus that resectable tumors are those that do not involve the superior mesenteric vessels. Borderline resectable disease is defined as tumors which abut the artery, either the SMA or the hepatic artery, and at least traditionally, locally advanced tumors were thought to be inoperable and encased the superior mesenteric artery or the hepatic artery. All of your individual multidisciplinary conferences will need to arrive on consensus on the nuances of, if you will, surgical resectability, which is critical to have a defined plan for that patient. I mean, I see at least 2 patients a week who are seeing me simply because they're still standing and they shouldn't be. So they've had a boatload of chemotherapy, they've had radiation therapy, and son of a gun, they're still there. And they say to the doctor, well, what do we do now? And it really was because there was indecision on whether surgery was part of their treatment program or not. And I'll talk about that in a minute. So a simple CT scan that shows a normal tissue plane between the SMA and the SMV, what would be classified as a resectable tumor. A tumor that would involve removal of the superior mesenteric vein. I think surgery should only be on the table if the surgeon who is going to see this patient has the technical ability to do this operation. And then a patient with classic borderline resectable disease who has tumor abutment of the superior mesenteric artery. When I was at Anderson in Houston, we started a template that now is actually taken up by the Radiology Society, and that's been continued in Wisconsin, where we have all of our CT reports are completely templated by the radiologists. So whether the patient has resectable, borderline resectable, or locally advanced disease is clearly stated, and the reasons why they have a specific stage of disease are also easily defined. This was the first manuscript that Gauri Vradachari put forth on the borderline category, and that was because we were doing clinical trial-based therapy for virtually all patients, and we realized for the first time, really, that we couldn't simply categorize patients as resectable based on their CT scan and locally advanced. There was something in between, as I showed you with those illustrations, where the tumor would then extend to the superior mesenteric artery. And the reasons for this are listed here. Our multidisciplinary team was committed to stage-specific therapy. We needed to accurately stage all patients in order to do a clinical trial. You had to define the population that you were studying. Accurate staging is necessary to clarify the goals of therapy. If surgery is an expectation after neoadjuvant therapy or not. I mean, I know all of you in this room have been left with a patient who comes back after finishing their chemoradiation, and the question is the tumor operable? And oftentimes, my surgery colleagues will waffle a little bit. And what we've tried to do over the last now 25 years is define exactly what is operable and what isn't. I can tell you that I learned virtually nothing in the operating room. The CT scan correlates 100% with tumor vessel anatomy. I think exploratory surgery is of value in trauma, and it certainly makes for very interesting television. But in cancer surgery, especially pancreatic surgery, it virtually is never useful. So this is the surgery first approach, just illustrated with a simple diagram. You can see that the patient is diagnosed, staging, and then they go to the operating room. Assuming everything goes well with their surgery, they're in the hospital 1 to 2 weeks. They recover for anywhere from 4 to 8 weeks, and then they begin, hopefully, adjuvant therapy after being completely restaged. And I know that the ACRO trial, which was pre- and post-op gem-Tarceva. I was actually in Houston when this trial was being conceived, and in the final hour, radiation therapy was dropped due to the SPAC trials from Europe, which arguably were about the worst trials ever reported, but they still made it into very high-impact journals. So these patients had no radiation therapy. The trial will be reported in ASCO. I'm really pushing the PI to report the local failure rate in these patients. But in any event, 40% of patients, and these patients were all hand-picked, because if you look at the institutions that enrolled the patients, and I'm as guilty as anyone. I moved from Anderson to Medical College of Wisconsin right as this trial was opening. We hadn't opened our in-house trials yet in Milwaukee, so we enrolled actually 7 patients on this trial. And they were, because of our underlying bias that radiation therapy should be part of the treatment for operable pancreas cancer, we hand-picked these patients. These were the smallest tumors known to mankind that could be FNA biopsied. And I'm sure that looking at the list of institutions that enrolled in this trial, they had a similar bias. 40% of patients who successfully underwent surgery did not get postoperative adjuvant therapy. So even if you have the greatest bullet in the world for this disease, it's a big operation. And we know that certainly in multi-institutional settings, upwards to 40% of patients will not receive intended adjuvant therapy if the patient is operated on first. In addition, what we don't know is the biologic impact of surgery first. Surgery is an immune suppressive event. To what degree does that advantage the micrometastases which may be present, again, in at least 95 to 98% of patients? And what we do know is that there has been no progress in decades operating straight away on pancreas cancer. As an example, a trial from Memorial in New York, and you can see here, They reported their experience over decades with the Whipple procedure, and the teal line is actually their most recent decade. No progress in decades with surgery first at an institution where they do the operation exceedingly well. The experience from Hopkins, and the thing that's interesting is the median survival of 2 years is so reproducible. If you do PubMed this afternoon and you look at all published surgery-first experiences, with or without adjuvant therapy for pancreas cancer, that 24 months will be incredibly reproducible. This is the experience from Hopkins, and a more recent experience published just recently from also from Memorial. And you can see here median survival of 24 months. So when you see that patient in the office, and I know it's a collaborative experience with the medical oncologist and the surgical oncologist, I just don't see why anyone diagnosed with pancreas cancer would go straight to the operating room. This was the first paper that we published when I was in Houston, and this was actually my fellow project many, many years ago. And we initiated this trial in the hopes of advocating for patients who represented early postoperative recurrence. So in my first few months as a surgical oncology fellow, I saw patients post-Whipple who came back at 6 months, 9 months, and they already had a liver metastasis. And we said, isn't there a way that we can advocate for these patients who have, if you will, bad biology, but at least they won't get an operation that then occupies about 1/3 of the remaining time on Earth. And that was really the logic behind starting this. There now has been a tremendous amount of work done. I just provide you some papers that we've published from Milwaukee that shows median survivals in various groups of patients that we've looked at either on or off of a clinical trial. And our trial of molecular-based medicine using neoadjuvant therapy will be presented this spring at the American Surgical Association. But you can look at the difference in survival numbers. I mean, it's, I think this has finally gotten people's attention to make them realize that treatment sequencing for this disease actually does matter. So we thought we had it figured out with resectable, borderline resectable, and locally advanced. So resectable and borderline resectable, surgery was possible. Locally advanced, surgery probably not possible. And again, important to have that discussion with the patient on day one. And then I saw this patient who was on the initial phase 2 trial of gemcitabine and nab-paclitaxel that Dan Von Hoff sent to me. And you can see here a big tumor encasing the celiac artery. And she was treated, and son of a gun, look what happened. And you've probably seen this with FOLFIRINOX also. Well, we have certainly the technical ability to remove the celiac artery, which is fairly straightforward if you've had a little practice with it. And you can see here the celiac artery is simply removed, and then we just put a saphenous vein graft in between. But we had to revisit whether this patient was operable or not. Remember, our obsession with making sure that each patient was appropriately staged, and therefore the goals of therapy were defined. So Susan Tsai and I put together this short paper in the Annals of Surgical Oncology, which then tries to define the locally advanced population into A and B, with the thought that locally advanced A, surgery may actually occur in the future. Locally advanced B, it probably won't. You can pull this reference. The details of tumor vessel anatomy get fairly complex, but it won't be that complicated if you visit this at your multidisciplinary tumor conference every week. And the radiologists and the surgeons, pathologists, everyone gets used to this. As you can see, type A, surgery may be possible. Type B, it won't. We then retrospectively reviewed our experience with locally advanced patients, and son of a gun, it actually proved to be true. So our hypothesis tended to be correct based on the anatomy of the tumor and its relationship to adjacent blood vessels and what we could safely do in the operating room. Again, our guiding principle was that surgical mortality for pancreatic cancer surgery should be 0 in a disease where you have a disease-associated mortality that is so high. Mortality from the operating room should certainly be 0. And you can see here in locally advanced type A patients, 62% had their tumors removed. To the extent that surgery is necessary, albeit not sufficient, for a long-term survival with this disease. In patients with type B locally advanced disease, it was much lower. So in the more contemporary experiences, a patient with a resectable tumor given neoadjuvant therapy, 90% of those patients will have their tumors surgically excised. Borderline resectable, it should be around 75%. Locally advanced type A, around 60%. And you can see how valuable that is to setting expectations for the patient and their physicians at the time of initial consultation. So just a couple guiding principles with respect to surgery, because I hardly ever get to talk to non-surgical audiences, so this is a particular treat. We don't operate on high-risk patients who need a high-risk operation, who also have a high-risk oncologic profile. So we basically look at three things: the comorbidities of the patient, the technical difficulties of the operation, and the oncologic picture of the patient. Has the patient responded or not responded based upon clinical benefit, tumor marker profile? We have a paper we're submitting hopefully tomorrow to JCO looking at the importance of 19.9 and a few other biomarkers, and what the CT scan has done. Is it stable? Has it responded? Or has it gotten worse? Survival duration is the primary endpoint. Quality of life is the co-primary endpoint. Just to give you some guidelines, if the survival duration is less than 1 year, surgery did absolutely nothing. One of the most important messages I tried to convey when I moved from a cancer center to a general hospital is that in cancer surgery, there are really no A's for effort. This isn't liver transplantation in a patient with a high MELD. I mean, if you don't operate on the patient, they will probably live a number of months or a year. So certainly if you operate on the patient and their length of life, in my opinion, is less than 2 years, then one could argue that surgery had either no or a very modest impact on the natural history of the disease in that patient, something I think we all need to remember. And of course, a commitment to multimodality therapy, and my personal bias that I think where we're moving to, because we can't reliably give adjuvant therapy, is a total neoadjuvant approach. That certainly is where our clinical trials are going. So I wanted to finish with throwing a little raw meat to some hungry wolves in the room, and just tell you why I think radiation therapy is important for this disease, and it's a huge mistake to eliminate it. Of course, I'm biased to pre-op radiation rather than post-op, and this also relates to my previous slide. A patient has to be alive in order to have a local recurrence. And if you have a median survival between 1 and 2 years, you're never going to show a benefit to local therapy. It's impossible. Now that we're seeing survivals in operable pancreas cancer of 3 to 4 years, you are going to see local recurrences if the patient is not radiated and does not receive a good operation. Carolyn Verbecki is a really talented pathologist who I've been unsuccessful to relocate to Milwaukee from Europe, and I'm still going to try. And this is a scheme, an illustration from one of her many papers that shows the fallacy of a negative margin and the fallacy of the path report. And you can see the red dots represent tumor cells, and the fact that after neoadjuvant therapy, it can even be more difficult. And that's because the autonomic nerves surround the visceral arteries, not the veins. So the autonomic nervous system goes around the SMA and the hepatic artery, goes right into the pancreas. The autonomic nerves can be thought of as miracle grow for tumor cells. That's a fertile area for them to grow and develop. And that's why this exactly happens, as illustrated by Carolyn. So this is in the operating room. Just to give you a feel for this, you can see the CHA is the common hepatic artery, PHA is the proper hepatic artery, and the superior border of the pancreas is everything in between. And if you look at this, now this patient has had neoadjuvant therapy. If anything, the autonomic neural tissue has hypertrophied a little, but what we've done here is we've basically incised the autonomic nerve surrounding the common hepatic artery, which is the focus, in my opinion, of local recurrences, and I'll get to the SMA in a minute, and why radiation therapy is important. And you can see that it's a grossly visible structure. that we have just opened up and we're removing. We actually sample this in all of our patients, and we're doing some neat studies in the lab looking at this neural tissue. So you can see here the autonomic nerve now with the artery in the middle, and that's what it looks like in a more high-powered view. It's now been separated completely from the common hepatic and the splenic arteries, but you can see that nerve. It's a grossly visible structure. And then we divide the pancreas along the anterior aspect of the superior mesenteric portal vein confluence. And then once the tumor is now attached only to the SMA, you can see that the visceral vessels have largely been separated. And I'm showing you there the SMA along its adventitia and the nerve tissue along the right lateral border of the SMA. So I think for all of you in this room, some interesting controversies. Number one, SBRT has taken the world over, it seems like, by storm, and it really doesn't allow for much of a margin on the tumor. Is that going to predispose to local recurrences? Many patients, at least published to date, have had IMRT with more conventional fractionation, where there is at least a margin on the tumors. So I think it'll be interesting to see what evolves over the next couple of years. But with that, I'll stop and thank you all for your attention. A picture of my two daughters on Lake Michigan who have taught me a lot about team sports. And I think caring for the pancreas patients, especially with neoadjuvant therapy, requires a team, which, as I mentioned, is the major impediment. Thank you all very much.
Thank you, Dr. Evans. That was excellent. I'm going to turn the mic over to Dr. Kachnik, and she's going to go over some cases in anal cancer.
So I actually just put 3 really hard cases on, but I see your SAM question, so don't worry. I'll weave that in, because I have hard cases, not really data slides, but I think these are presentations that you will all have at some point if you treat GI. So the first case is a 63-year-old gentleman with a history of HIV. He had a CD4 count of 190 and a history of B-cell lymphoma. And he presented with rectal pain, bleeding, an abnormal anal pap, and high-risk HPV positivity. So on his exam under anesthesia and on my digital rectal exam, he had a mass in his canal. It actually started outside of the verge. He called it his Himalayas, and I just saw him in follow-up Tuesday. It was good. And it was about 6 cm in total length, so Himalayas and then up into the verge. Biopsy showed moderately differentiated squamous cell. It was P16 positive. And a PET scan confirmed my exam findings, but also had a left inguinal node that wasn't quite as avid as the primary, but we considered positive. So I do show you one thing, because this has changed. So the stagings for the T stage is the same, and it's akin to head and neck and skin. But the nodal stage changed, and probably changed for the better, because the way it was before, not that we failed Giannia oral boards, but it was sort of not intuitive. Before it was N1 was mesorectum, N2 was inguinal. But whether you're positive in your mesorectum or you have an inguinal node positive, honestly, the prognosis is pretty much the same, because for anal cancer, it's really based on your primary tumor size and your node positivity in general. So I like this change. So basically, everybody is N1, but now A, B, and C. That's not one of your SAM questions, so don't worry. So look at this. This is our NCCN guideline, and pretty much nothing's changed for anal cancer since Dr. Nigro, a surgeon, started this regimen in the 80s. We know a lot more about it, that pretty much 5-FU and mitomycin with radiation is still the combination. And we know that, now these are your SAM questions, The reason for this is if you try to get rid of the mitomycin, you impact local control. However, the bad part of mitomycin is that when you're following a patient for acute toxicities, it's a real stinker in terms of hematologic toxicities. That's the number one, although you'll get some skin and GI as well. But the skin's much better since we started doing IMRT. So PET imaging, thank God, was finally put on NCCN guidelines as a recommended baseline standard. And I find it really important as it guides my radiation planning. Lots of times, although I think I've been more sophisticated over the years on a good CAT scan, looking at sort of big plumpy nodes that have fat around them versus not to kind of tell what's positive or not. But the PET makes it easy because it typically, you'll have increased uptake. It lights those nodes up and really helps with the primary between your DRE, the surgeon's anorectal scope exam, and the PET scan on top of your CT. I find the CT for the primary sometimes is a little hard to guide for my radiation planning, and my exam is often better. And also for folks that have Himalayas or disease outside of the rectum, putting an anal wire marker around that helps on your planning as well. So here on the PET scan, I don't think I have a pointer on this, but maybe I do. Do I? I don't. Do I? No. Anyone have a pointer? Okay, that's all right. So if you look at the top right, you can see on your right a little faint inguinal node over there. It's about 1.5 cm. And then you can see it light up nice in the bladder, but also the primary. So I'm going to actually take you slice by slice on the next series. But I found when we started doing that single arm R2G 0529 trial that putting patients prone instead of supine gave you a little more bang for your buck in reducing the GI toxicity if you put them on a belly board and try to get that bowel up out of the way of where you're going to treat the presacral and iliacs. And remember, what's your target for this? So your primary, and I'll go over that in the next couple of slides too, but you're treating a lot of elective nodes. You treat the mesorectum, so the rectum is actually target. It's not just the anal canal, the whole rectum is target, and the mesorectum. The inguinal, the presacral, and the internal and external iliac. And on 0529, we kind of dosed it based on stage with IMRT, just doing one plan because folks on a trial aren't going to really want to do 2 IMRT plans to kind of do the sort of primary and elective nodes to what we used to do at 2D, which was 30 to 36 gray, and then come off and do another plan. So we dose painted. So for smaller lesions, to kind of go akin to what we did with 2D, on 0529, we gave 50-40 gray to the primary in 180s. And when you do your primary, I'm going to show you in the slide, so I'll tell you then. I'll show you how to draw it. And then for the elective nodes, since it was a combined plan, for the smaller stage disease, they got 4,200. And then lymph nodes, we actually dose by size, although honestly, if you take them the same dose as your primary, it's fine. But we dose them on 0529. Smaller ones got the dose of 50.4 gray, and larger ones got 54. But for T2N0s, 50, 40, and then did I say 45? 4,200. So he had the Himalayas, so he gets the higher dose. So for T3, T4s, or N positive, we do 54 gray and 30 fractions. And that inguinal node, since it was small, got 50-40. And this is just sort of the composite, and I don't have a pointer, but the red is sort of the primary disease, which when you're going to draw it, you'll do the anal canal plus your actual primary, and then you'll make a radial margin If you're doing daily IGRT, I think 1.5 cm is fine, although on 0529 we did 2. And then you can trim off of the sort of bone and muscle. But just be careful because in this case, you have to make sure you're covering the external disease, and that margin will go, oh, yay. That's going to be helpful. Okay. And then the green color wash here for him. I see the red button, but. Around my glasses. Nope. Okay, well, you found my limitation. I'm blind now, too, but I didn't turn it on. Okay, so then the green color wash, in this case, is 4,500, because if we're doing things concurrent in 180s, it's 54 to the primary, it's 45 to the elective nodes, and again, dosing positive nodes based on size. So I presented this case for a reason, and I will get to that, but let's go through, I think on the next slide, hopefully this atlas will work. And I gotta I'll give a shout out. We have another one of our residents in the audience, but the resident who did this for me is not here, and I don't know how he did it, but I need to learn because it's really clever. And his name's Nitesh Rana, so he gets a shout out from me here. So on this slide, they're gonna control going from slice to slice for me. So I think our audio-visual folks in the back. But I usually start on top, right under the common iliacs. And if you see, you have your external and internal here. And I typically put about a 7 millimeter margin around. And I make sure pre-sacrally it's usually about 7 millimeters to 1 centimeter in front of the bone. Next. And you can see, same here. You see it better here. Next. So now, we're going to start coming into where we see the rectum, and that's hard too. So I kind of say if you have the donut hole, you're still in the rectum, and when you see it start turning sideways, that's when you get into the sigmoid, and you can start coming off. This doesn't illustrate it well. Hopefully one of the other cases will. Next. Well, here's you're in the sigmoid, and then here's you're coming into the rectum, so that's pretty good. And you have your external now trying to go down a little bit. Next. And next, you really put every slice here. You're getting the sense, and you see a little margin in front of your external. Next. Next. Oh, this is a good one. We're getting into where the rectum here, we're starting to get in some mesorectal tissue. Next. Next. And so now we're really into the heart of the mesorectum, and his tumor's so big that this starts to get into that high dose region. And here you're going to see almost magically on the next two slices that are what we considered external iliac is turning into the inguinal artery and vein. Next. Magically, and I didn't even remember reviewing this. So. But you can see it, it doesn't matter, you're going to cover it, but it's usually when you kind of get that pelvic bone change that you can notice it's inguinal artery and vein here. So this guy's bladder is starting to come into play, but I make sure prone, they've actually been moving their bowels, so I don't have a big air thing in my rectum, which won't reproduce on the daily treatments, and full bladder. And then when I draw my CTV, I usually make sure I have a little lip of the bladder, just in case that bladder filling is a little bit different from day to day. And then for the inguinal fossa, and we won't have to show this as in-depth on every case to save some time, it's not just really 7 millimeters around the inguinal artery and vein, although we kind of said that in our first atlas, but it's not big enough. So if you look at, we have a second atlas out. It's actually an Australian atlas, but I helped them do it. We gave really good muscle directions for both the pectinus and the saphenous muscle here to guide a little bit more robust drawing of your inguinal, contouring of your inguinal fossa. And then I also include reactive nodes because if you see them, bless you, if you see them, that's likely your fossa. So next. And next. Keep on going. give people a sense of it. Yep. And again, these are actually your CTVs. Okay, good. All right. So I brought up this case, if folks can remember the presentation now, because the CD4 count was low. So I'm not showing you the data, but RTOG 9811 was a trial that looked at substituting the mitomycin because of the hematologic toxicity with platinum. Unfortunately, they gave a run-in on the platinum arm of 5-FU and platinum, so it was sort of not the best study design. A 2x2 would have been better. But the platinum arm did much worse. So based on that, we still used 5-FU and mitomycin. But then the UK did the right study. They did a 2x2 design, but they asked questions in terms of primary and secondary endpoints, looking at platinum with an improvement in both their primary and secondary endpoints, and their trial failed to show it. So it wasn't set up as a non-inferiority trial, but it did tell us it was probably okay to use platinum, at least for patients that have an issue with hematologic toxicity, even though that's not the primary or sort of second randomization primary endpoint of that trial. So patients, if we're worried about hematologic toxicity, which we do when they have CD4 counts less than 200, we typically do the 5-FU and the platinum. But otherwise, I always do 5-FU and mitomycin still. And these are all recent cases from Vanderbilt. I was like, wow, I thought I had some great cases in Boston at my safety net hospital, but no, they kept on coming at Vanderbilt. So the second one is really interesting, and you might get it for some sort of pelvic presentation, whether it's anal, rectal, a GYN case. And this was a 58-year-old female with the history shown there who had a renal transplant in 1988, and her only remaining kidney sits in her right pelvis, and not so low, but you saw how high these fields go, so low enough. And we didn't write this in here, but she called it Lily Bell. And she presented with rectal bleeding. I thought I'd get a little more laugh at that she named her. It's true, though. Diarrhea and constipation. And she was actually noted on her GYN appointment to have this mass, which makes me remind everyone that part of the workup, because this is HPV positive, not only doing an HIV, but looking in the areas where you might have other lesions from HPV. So it's really important before you do IMRT to check both females and males for those other organs that might harbor P16 positivity and lesions. So she was good and just went for her annual appointment and found to have a squamous cell. Luckily on her exam, this was a T2N0, and the lesion was a little bit smaller. And that's important when I show you what I did. And she was HIV negative. So her PET, actually we could skip that. We'll just go to the, so for her, I show you this part before we go to the atlas, mostly you can kind of see on her coronal what I did. So I went a little lower on the upper coverage because her kidney kind of sits right here, which I'll show you on the actual atlas slides. Because she was a T2N0, we went to that lower dose, and her elective nodes got 4,200. Oh, and I should have probably mentioned this for the last case, because I usually get asked this. I don't ever use inguinal bolus unless I got some honking tumor like coming through the skin. But for the Himalayas on the last case, because I had disease outside of the verge, I typically find that if I do bolus every other day, and I still check it with diodes or TLDs, gives me about 180, on average throughout the course. On this case, I didn't need any, but I still checked with diodes or TLDs because all of her disease was in the canal. So if we put that on, I won't show you how I draw, but we'll just go through slices. There's our kidney. You can just go through. I'll tell you to stop if we So I just went lower, but you still see the same sort of field design. I gotta say, we've gotten better about filling our bladders. These were all cases from 2 years ago when I started. So this one, you will probably see one of these. I've only seen, at least with anal, one of these, and just happened to be after 25 years of doing this. But I think you'll see a case of this where you need to kind of think up a little bit out of the box on the pluses and minuses. She was not medically going to have an APR, which is the other treatment for this disease. So we kind of had to do that. But she's doing well because she's about 2 years out now, too. And 2 years, maybe it's a point where I could talk a little bit about follow-up. 2 years is pretty good prediction for remaining disease-free. When I look at all of the R2G 9811 data, almost anyone that recurs by 2 years. So I think with pretty good confidence, if a patient has no disease, then they'll stay disease-free. And when I do follow-up, I check month by month until they have a complete response with digital rectal exam. And as long as things are going in the right direction, I don't biopsy. At any time where they have progressive disease, it's time out, investigate with imaging and an EUA, and then biopsy and consider APR. If it's something that's kind of going slow, I don't really worry either, because if I look, that Act 2 trial, which was the better platinum versus mitomycin trial, their sort of sweet timing for complete response was 6 months. So I think that's also good timing. And just one other follow-up caveat, imaging. Imaging isn't really that helpful. This is more helpful or looking with an anoscope. But if you're allowed by your insurance company to do a PET, a 3-month PET is probably the best. Don't do it before. You'll still have increased uptake. All right, last case. Do we have time for one more case? Okay, we're gonna skip the last case, but I'll tell you what it was. How's that? So remember I said GYN exam is important? So it was a woman who, when I had her go for her GYN evaluation, was found to have VIN3 of the vulva. So we decided that, and I had done this before, this wasn't a unique case to me. I treated the vulva in the elective nodal dose, and she's been followed now for 2 years, and she's also fine. She hasn't gotten any new dysplasia or lesions, and really no toxicity from it. And I think that's it, except I still do provide vaginal dilators, although with IMRT, I don't probably need it, but I still do it.
Thank you, Lisa. We got 3 instead of 2, so that was great. 3 cases covered. We have about 10 minutes for questions, and so if anyone has a question, either just raise your hands. I don't know where that mic, round mic was going, but if somebody has a question, please just raise up. And there's some hands back there, so all the way back at Brian.
To make me walk, huh?
Back where? Okay.
So we got one there. Ready? Ready for this?
Yeah, they're
Right. I have a question for Dr. Evans. What are your thoughts and your practices related to sort of adjuvants to surgical resection, like irreversible electroporation?
That's, is this mic on? Can you hear me okay?
Yeah.
That just makes no sense to me. So, sadly, I'm old enough to remember the IORT experience. So, for those of you who are my age or older, you remember that it initially started with an experience from Thomas Jefferson. And then we did some IORT when I was at Anderson, predominantly an operable disease. But I mean, sadly, to think that you're gonna, IRE is used in 2 ways. Number one, it's used in patients who are thought to be inoperable, and therefore the decision is made to provide a local therapy. And to operate on someone who has incurable pancreas cancer, when you could give them, and again, I don't mean to sound like I'm just playing up to the audience here, but when you could just simply give them external beam radiation in whatever fractionation schedule you would like, I think is really crazy. And then the other bad thing about IRE is it's used as a crutch for surgeons. So if the surgeon in some cases doesn't have to actually state whether this is an operable or an inoperable tumor. It takes us back, 30 years when I was a medical student working with John Brash at the Leahy Clinic, and we were determining operability at the time of surgical exploration. So I think it's for those reasons I think it's just awful. And if you do PubMed on me, you'll see that I take a pot shot at IRE in virtually every manuscript I can.
Okay, thank you. Are there any other questions? Okay, go ahead. There's the mic, somebody's at the mic, go ahead.
That box is funny.
Make a comment about HER2 status in esophageal cancer, therapeutic and prognostic,
Right, so.
duration of Herceptin and so forth.
Sure. So here too in esophageal and gastric cancer is a little different than in breast cancer. These tumors tend to be much more heterogeneous. So the expression, I've had cases that are reported as HER2 negative, and then subsequently we've done a repeat biopsy to send for next generation sequencing or something, and a different section of it is HER2 expressing. So it's a tougher evaluation to do. But those patients that do express HER2, they tend to do better. And whether it's just because of the trastuzumab or they're just, they're molecularly just better behaving tumors, all that's being sorted out. But their prognosis is significantly better with the addition of trastuzumab. There are a number of studies looking at the addition of lapatinib and whatnot, and as of yet, combinations haven't made a difference, and we haven't had the impact that they do in breast cancer, but it certainly has changed the way we treat those tumors. And hopefully that's just the beginning. There are so many different molecular pathways that we've found throughout the esophagus and gastric cancers. And I've said this before, but I think it was a couple of years ago, I said that is the next big breakthrough, is the molecular pathways of esophageal and gastric cancer. I think we're going to start seeing some more targeted therapies.
Okay, great. Thank you for that answer. And there's one in the front here.
Yeah, I just had a couple of questions. One in regard to benefit of EUS if a patient has positive nodal disease, like that, for esophageal cancer patients. And then two was what the elective nodal radiation for esophageal cancer patients, if found to have some cloud node, would you electively treat the contra levels of the cloud as well?
You're asking me or radiation?
I guess.
I could start with the EUS. So EUS.
Can you repeat the question? 'Cause I'm not
So
sure.
the question is first, the role of EUS in somebody who's got lymph node positive disease, right? And then the second one is the role of radiation for distant lymph nodes. Is it
Elective nodal irradiation.
elective nodal irradiation?
I can comment.
I'll give you that one. So, so for the EUS for lymph node positive disease, the reason I find to do an EUS mostly, there's certainly one-offs, but mostly it's for surgical planning. So if somebody's going to have an operation, then we'll do an EUS. They want to see the planes. They'll want to know what's going on. But so regardless of if there's local lymph nodes, yeah, I still do an EUS. So, but it really is driven by the surgeon. And then I'll hand you distant lymph nodes.
Maybe oh, good, I'm on now. I think that turned me off, which might not be a bad thing. So elective nodal radiation for esophagus. So, I mean, I think it's sort of targeted elective nodal. So if you have a distal lesion, and let's just say we don't see any nodes, we typically electively treat the celiac axis, so all that nice rich tissue between the celiac and the lesser curvature of the stomach. Up to the point where you see the kind of take off and then not so much after that. However, I guess the judgment call is kind of when you have a lesion on both sides of the carina, so at about 25 cm, like kind of what do you do? And to me, if your PET shows you, nothing up and nothing down, I sort of just put that mucosal margin on that sort of lengthy esophagus lesion and call it a day. Interestingly enough, but I think it's premature data, I think at the plenary, not last ASTRO, but the ASTRO before, we had a group from Asia show a randomized trial of extended nodal irradiation or not, and I don't believe, I think they didn't show a difference, but now I don't remember the results. I do have a slide though. But in any case, I usually treat sort of common sense. So under the carina, I'll treat the celiac. Over the carina, I'll do bilateral superclav. So if I had a lesion above the carina with one side fossa positive, I'd treat both. Does that answer your question? Okay.
Thank you. This is really cool. You all had really good talks. I actually have questions for almost all of you, but I'm going to pick Dr. Evans instead. My question is, you said something interesting regarding the immunosuppressive effect of surgery, which I know has been quantified in other disease sites. I'm not personally as familiar with the pancreatic cancer data, but I want to know if it's been studied or if there's been any type of quantification of cellular response or neutrophil to lymphocyte ratios or anything in terms of how the immune system is functioning when you're doing neoadjuvant chemoradiation prior to surgery versus surgery, and whether that could correlate with survival.
Yeah, I mean, you're absolutely right. I think there's not really a whole lot of information on this. It's really just the clinical observation that that frequently after a big, and I think everyone has seen this, after a big operation, all of a sudden the distant disease kind of flowers, if you will. And one of the, as I said, the reason we began neoadjuvant treatment sequencing initially was really to advocate for those patients who are destined to fail early. It's amazing how you can't predict what the audience will perceive. That really had no impact on the medical community. The reason why neoadjuvant therapy now is more appealing is because of the survival data that is seen in patients with who have completed all intended multimodality therapy. Not to mention the fact that probably for many people who are in smaller communities or even in larger cities, it's pretty. The insurance outside of a clinical trial, the insurance companies typically, and Mary can comment on this, won't approve FOLFIRINOX, GemNab, et cetera. You're left with GemCape. So I think that, if anything, probably outside of clinical trials, is driving a more realistic neoadjuvant approach. We'll have a paper looking at a bunch of immune markers of tolerance, but unfortunately, because we're a little bit biased, we won't have the surgery first patients to compare it to. It'll just be the effect of neoadjuvant therapy with respect to a variety of immune markers.